Was that true with like all of UW or just
no,
the
just
east side?
just the east side.
Oh, yeah.
They're still doing endoscopies and things. I don't know how they're doing it.
Surgeons don't need charge.
Well, they print out their pictures and.
Such a sucker. Just like everybody else is all in them. Yeah. So
Put a note off, open your sandwiches ahead of time.
I know.
It is loud. I was listening.
It is loud. If you listen on all of the
Background noise is the worst.
because you know the speakers like. I mean, I don't know why they do that. You know, they should just have the speakers here and not.
It's loud. I was listening a few weeks ago.
I was at EoE talk with the quad.
Dad out of town?
No, he's in town.
I think we're going to have a short meeting. We're mapped out now, but we just have a so we need to 8 o'clock instead of 7:30.
Barbieri or something like that. Lives an hour and a half from Great Falls, and she's in a wheelchair because she had. We've had live people.
Yeah, I know. I haven't seen it. I've heard of that. So it's a good song. Because
she sounded the first one was garbage. The second one was half garbage, but had 2 population cells.
no, that's not yeah, no, it's a good idea. So if they can't come out. Tomorrow, yeah.
Did you come on the new bridge?
I did. That was the first time I walked it, you know, on the weekend. That was a lot of fun. Yeah, it's very clean. There's no choice. You get jacked and then jacked back.
No.
Still have a bottle for.
Yeah, and I don't think they'll finish the other side.
They're open.
She's good. She's hard with them.
Yeah,
The eastbound.
the eastbound, right. But still, you'll have the 2 to 3 to.
Yeah.
Yeah.
They.
But I don't think the
crazy.
long lane with the bike lane and the running lane will be open for use.
It looks that really good.
And it's really nice. I walked part of the Saturday on the bike lane. It's very nice. It's pretty wide. It's separated by the huge concrete barrier, so you don't have any fear of anything happening. Yeah. The biggest fear is being run over by a bicycle.
I was like, I'm on the new bridge today.
Tearing down the old bridge.
Controversy? Yeah.
Well, they're going to take all of the sections and crush all the concrete.
And then I think there's
Yeah, but then the only concrete.
What is it?
On all the concrete. Say it's a health hazard and they were self.
They're probably fine when they're building it up there because they're employing people. You gotta probably employ people in practice. I know, I don't do it. No, because it's not available. It's still available on phase 3 study. Oh, is it? Yeah. Indication probably be for EOE-OVB. And it's projected to be out in first quarter 2017. So, and then after that, it'll probably be severe asthma and mollusc, but the first indication will be severe AD.
Yeah, your craziness.
No, it's
Come out.
Hey, all right. Good to see you.
There should be
next year? Spring 2017. First quarter is 2017.
I had one day where we got
Yeah,
in the morning.
you know, that's different.
They'll take a while.
From That's the new grievance.
Me too, it's pretty nice. Did you walk on Saturday or run?
No, I didn't. I was at it.
It was so much fun.
Like when I
It was,
run?
no, I walked it, but I walked from the east side to the west side and back, and ran into everyone, so many people. I mean, it was like a picnic.
I saw the picture. Like I'm not going to take photos. Well, the other thing I heard was it's very hard to get there because there's traffic. Of course, the bridge is going to be closed. They have to drive around.
Well, I have a friend who literally walked from the Endoscopic side, and we just drove to their house.
Oh, and walk there.
And then I didn't have to deal with the shuttle buses with her a little bit.
Yeah, I heard it was like an hour. Good morning.
Yeah, when you call the vascular surgeons, they say, oh, okay, my vascular developed that's the but he referred me on to the right guy, and I think it's going to happen, and I told the patient how to make it close. I had to write an order for it.
No, that's good. I never know whether they do them or not.
So that got me on the right path.
No, that's good.
So she's been just like taking
So recently, all the technical stuff seems to be working. I know. Always.
Bad
I
habit.
know.
For a while,
I like donuts.
No, you put the kibosh down on that. I got it.
Oh, yes, Cheetos. That might be a bit much for breakfast.
I don't remember to sign in to
It's amazing how
to sign in and then sign in full to the job.
We're working at it.
which is a problem. I did this on Tuesday.
Yeah, you got green dragons, people right here.
Excuse me now.
Mike had taught me how to do that like 10 years ago.
Shot ourselves.
I didn't have it yesterday.
Four right here.
I had a pediatric resident with me yesterday, and she watched me charge because she had an offer to get to train, I guess, 2 hours to get drag in the university system. She said after watching you do it.
Oh, dude.
So you probably take a little bit more than that, but not much more. Just to learn how.
I don't think it takes 2 hours to learn.
I think I didn't recall. Best tendency starts, and you read those as you train it, so it's learning those words. And then, yeah.
It's getting better. It's better less than it was. Jacob, but it had a
You have a cat.
Yes.
Cat doesn't do very well with, for me, soy has trouble with.
Soy.
It goes so up. But if I say soy, it's going to be fine. So I just say soybean. Yeah, well, it teaches me.
And essentially, you get that choice.
Yeah, I used to call it xenography.
If you say cat something, it's capitalized.
Yeah. I mean, considering it's amazing with the technology.
But you know what it does wrong? You get all the
River cruise. I did.
Yeah.
Ocean cruise in March.
I did the giant cruise.
So I've gone on a trip from Budapest to March.
No, I love it. So you have to go.
Well, I've never been to that.
Here's the trip. I'm going to
Extremely complicated.
No, it's fun. There's a lot to do on those trips. The one I'm going on from White from St. Petersburg, all the major capitals of till then in Estonia, Berlin, Stockholm, and go to Helsinki and Copenhagen, and all the a bunch of the northern fields. It's all just 2 weeks.
Well, it's spring break. It's
It's all inclusive, including all day trips and all foods. There's only 5 minutes.
I wrote. Did you see what I wrote on there? You can change that, I guess.
It's a hell of a deal.
Yeah, it's fine. Just
Signed up for
What are the days in New York?
12 of us that are going.
One year I made it.
Because you have measurements of what it means. Yeah, like every year. Screening session has to do with all right, so Mike Weiss is our presenter today. This is a topic he sees a lot of patients. I know is very interested in. Went to the all-day course at the Quad AI meeting this year. So I'll be interested to see what new things you can take home from this. So Mike, Eosinophilic Esophagitis. Next week we have journals. I don't remember who, but I'll contact you.
That was me.
Are you? Oh wait, yeah.
Didn't you
I had to
switch?
switch, right?
Yeah.
You're the presenter.
Yeah.
You're doing the entire universe in 1 hour.
Yeah, thanks for remembering.
Thanks for the assignment.
No, the assignment's great.
Well, thanks for coming here. I hope people are not expecting drug allergy as it was originally listed. After Matt Alden did this tour de force talk on drug allergy, and Frank also did a journal club on it, Len and I decided to switch the topic to something that I am very interested in, eosinophilic esophagitis. I did go to the all-day symposium at this year's Quad AI, as I did about 4 years ago. So we're going to try and condense an all-day symposium into a sort of 50-minute talk and give you the highlights. If per chance I don't get through everything, you'll have the slides there. But I did try to give as much as possible here. So no disclosure, so that's easy. So the history for EoE is fairly interesting. It wasn't really recognized until some scattered reports started coming out relatively recent in the 1990s. Previously, the presence of eosinophils in the esophagus before then was thought to indicate reflux esophagitis. But at the time, they started to notice that clinical symptoms and histologic changes in these patients did really not respond to acid suppression or anti-reflux surgery. So it suggested that this condition really was different than or distinct from from gastroesophageal reflux disease. And really, this field exploded starting in 1995 when Kevin Kelly and Hugh Sampson described 10 children at Hopkins with EoE. And they successfully treated these 10 kids with elemental diet. And then all of their symptoms returned when they reintroduced foods. So again, once considered a non-disease and then a rare disease, it's now one of the most common conditions diagnosed during the assessment of feeding problems in children and during the evaluation of difficulty swallowing and food impaction in adults. So it does seem to exist worldwide, but it's been most extensively studied in Western countries, and the prevalence has been estimated at this point to be 0.4%. And right now, 50% of the current literature in EoE has been published in the past 3 years, and that was of 2014. So the literature in this topic is really exploding. So it's just, you know, an all-day symposium, and they still couldn't get everything in probably that they wanted to. Whether this is really a new disease or simply one that hasn't been recognized is being debated. I think it may be a little bit of both. I think without endoscopy, or at least flexible endoscopy, you're really difficult to make this diagnosis. But it is felt that EoE, along with most of the other atopic diseases in sort of westernized countries, has been clearly on the rise. So it's probably a combination. So it's currently defined as a chronic, antigen-mediated, immune-driven esophageal disease that's characterized by symptoms related to esophageal dysfunction and eosinophil predominant, not exclusive, inflammation. And clearly the dominant antigens in this disease is food-based. There have been some reports of seasonal flares in patients with very strong pollen sensitivities. And very often you'll see a personal or family history of other atopic diseases in people who have EoE. such as asthma, eczema, rhinitis, food allergies.
I can ask you a question?
Sure.
Why was it thought, or why is it still thought, that reflux gives you eosinophilic inflammation in non-atopic people?
Yeah, so, when people were first, again, with the onset of flexible endoscopies, they had rigid ones before, which, it's a whole big deal. You had to go under and blah, blah, blah. So when they started doing more flexible endoscopies, some of the gastroenterologists in their GERD patients would find eosinophils distally. And they said, oh, that's part of GERD. But then again, as they started to see more and more, and they didn't respond to typical GERD treatments, then people started to realize that was not the case. So they felt acid-induced eosinophils initially.
But I mean, that's still something you have to exclude.
Yes, well, we'll get to that.
Okay, all right.
Yeah, we'll get to that. So how it presents, and it does present a bit different in children and adults. So in children, it's often feeding difficulties, sometimes refusal to eat, nausea and particular vomiting, and eventually in some of the kids, failure to thrive because they're refusing to eat or they're vomiting. In adults, it often will present with difficulty swallowing and episodes of food impaction. Very often, I'll see a patient, an adult in the room who's had a food impaction, ended up going to the ER, diagnosis was made and was referred over. And if you take a good history, you say, oh, so you've been having some trouble, swallowing, and they say, sure, for the last 30, 40 years, I've had trouble swallowing, but it's no big deal. I just do this or this or this, until eventually that didn't work because they got a food impaction in one of their fibrostenotic areas. Currently, if you have someone who goes right now, not in the past, but right now, if you have someone who undergoes endoscopy for a history of food impaction, diagnosis of EoE is made in 54% of the time, so over half of those people who have food impaction will end up having a diagnosis of EoE. And again, many of these folks have this very subtle accommodation over multiple decades. They eat slow, they chew carefully, they cut their food into tiny pieces, they actually lubricate their food with sauces and liquids to dilute, they avoid pills that are large, and they've just learned really, and some of them won't eat bread or meats, breads in particular, because as you swallow breads, they take on moisture and expand and can get very sticky. Some of them, in fact, many of them are felt to have chronic GERD symptoms as well. So there's differences, and these differences have been tried to explain in pediatric and adult patients. So the clinical presentations, as I mentioned, are sort of different. There are some differences in response to treatment in patients, kids versus adults. And the question sort of came up, is this the same disease or is it really two distinct disorders? Probably the most relevant differences between the pediatric and the adult patients comes from basically the changes in this disease over time, because you don't have fibrostenotic changes initially. It takes years and years of eosinophilic inflammation for that to occur. And so that's one thing that happens. And then also the ability to express symptoms is different in adults versus infants. Basically, it's felt, most studies support that this is a common pathogenesis and a similar histopathologic features, and it's just the continuum of this disease progressing over time. And again, a study observed that 85% of adults had untreated symptoms for 20 years before they eventually presented with esophageal strictures. So this is probably one disease that manifests itself differently based on the time of the disease and the length of the inflammation. So again, diagnosing it. So we've talked about symptoms. Obviously, your patients have to have appropriate symptoms, and we've talked about those in kids versus adults. There can be a chest discomfort, and I've had a number of patients who really didn't have impaction, but they had chest discomfort, and when they went and had their endoscopy, again, the diagnosis was made. And when you treat these individuals appropriately, their chest pain and chest discomfort goes away. You have to have eosinophils of at least 15 per high-powered field on the biopsy. And you have to exclude, as Len was alluding to, other cause is particularly GERD. And so in an ideal world, and this doesn't happen all the time, in an ideal world, the patients have had high-dose proton pump inhibitor therapy, BID therapy, for 8 weeks before they have their endoscopy. It just doesn't always work out that way. Patients who end up in sort of ERs with food impaction, you're going to have your endoscopy quicker and sooner and possibly make that diagnosis. But you do, in a perfect world, want to put patients on who you suspect with proton pump inhibitors before referring to your favorite gastroenterologist. There are some other rare diseases of eosinophilic esophageal disease, parasitic infections, allergic vasculitis, etc., Crohn's of the esophagus. I recently had a very interesting patient who had an adolescent who had documented endoscopy findings of EoE, was an atopic individual. Usually would go pretty well with treatment, but occasionally would just go crazy with symptoms despite pretty aggressive treatment, including recently oral steroids. And I was sort of pulling my hair out, and I sort of referred them to children's GI, and diagnosis was made of a condition called rumination syndrome, where the muscles of the stomach just periodically contract, causing spit up and vomiting. And we're currently tapering this patient off a lot of the medications. So there are some other unusual things, and you definitely do need to work with a gastroenterologist to help figure out people who are not, being treated correct or not responding the way you'd expect. So on endoscopy, they'll often see white specks, which are basically eosinophilic abscesses, often mucosal edema, linear furrows, and in the worst cases, you'll see esophageal rings and strictures starting of a fibrostenotic disease. And the endoscopist often will describe a crepe paper esophagus where they'll get linear tears with minimal trauma. In fact, even just passing the endoscope often will tear the esophagus. And then the endoscopists also have described what they call a tug sign. And it's just basically a firmer feeling sensed by the endoscopist when they're doing their biopsy. It just feels different to them. The esophagus is usually devoid of eosinophils, and so you need eosinophils, obviously, to make the diagnosis. And the cutoff of 15 for high-powered field is thought to approach a sensitivity of 100% and specificity of 96% for establishing the histologic diagnosis in the proper clinical setting. And again, aggregates of eosinophils are often seen. They often will also have dilated intracellular spaces, basal cell hyperplasia. And what's also very interesting, and we'll come back to it, there's a whole host of other inflammatory cells along with the eosinophils that are seen there, including lymphocytes, mast cells, and basophils. And here's some histology. The small arrows are the increased eosinophils. The large arrow is dilated intracellular spaces. The circle is basilar cell hyperplasia, and then the bracket is papillary elongation. So all of these features found in this one particular patient.
Is the pathology only found in the esophagus, or has anyone actually seen whether if you continue and do upper bowel that you've got some?
Yeah, those are usually normal. Yeah, those are usual. So some eosinophils are found in the stomach and the duodenum, but the numbers are not typically increased in patients with strictly EoE. And here's a look through an endoscope of concentric rings. Again, this is going to lead to fibrostenotic disease, and on the right is, again, just a histology showing increased eosinophils. Barium swallows definitely have a role in diagnosing this disease. Strictures in patients with EoE may be very lengthy, they may be tapered, and they can sometimes escape detection of the endoscopist because of the subtleties of the stricture. Reports said that 71% of adults and 55% of children who had both endoscopy and barium swallows, the strictures or narrowing was not recognized at the time of the endoscopy, but had evidence of that on the barium swallow. And then there was a study in children where the stricture was identified during the barium swallow alone had a shorter duration of symptoms, 2.1 years versus 5.4 years when the diagnosis of stricture was made by endoscopy. So you may be able to see the narrowing sooner. So something to think about. We don't use it all that often anymore, but it certainly has a utility here. So genetic predisposition, it's very much male predominant, 3 to 4 to 1. Family history of EoE is frequently reported, and the heritability risk is estimated to be 2%. A lot of the work done by Mark Rothenberg and his group found 3 important genes with in EoE, the calpain-14 gene, which is a calcium-dependent proteolytic activities caused by calcium-activated neural protease, has been found consistently. It's interesting that IL-13, which may be a critical cytokine in this disease, upregulates this calpain-14 gene. Thymic stromal lipopoietin has been found, and eotaxin-3, a very important chemoattractant for eosinophils and basophils, is definitely upregulated in this disease. If you look further at genetics, if you have monozygotic twins and one of them has it, 41% chance the other monozygotic twin is going to have the disease. In dizygotic twins, 22% concordance siblings, about 2.4%. In the general population, 5.5 out of 10,000. In 2004, it was reported that there are 1 in 10,000 new cases every year with a prevalence of 1 in 2,000. But there's been a 10-fold increase in the prevalence in the last decade. Again, awareness, increase in atopic diseases, more endoscopies. So 10-fold increase in the last 10 years. Mark Rothenberg and his group in Cincinnati developed a very elegant EoE diagnostic panel, which they termed EDP, and it comprises a 96-gene quantitative polymerase chain reaction array, and they vetted this EDP using both pediatric and adult patients who had active EoE, and they also compared it to controls, patients who didn't have EoE, and then also patients with EoE who were in remission, either with dietary or pharmaceutical treatment, and also in patients with reflux. And this panel identified patients with EoE with approximately 96% sensitivity and 98% specificity. Let me show you this. So they go in, get tissue, usually through biopsy. They do RNA extraction. And then at the bottom,
There's a pointer there.
there we go. Okay, so this is the transcriptome, and each one of these columns is a patient. So you probably have about 20 patients, 15 patients here. And these are the different genes that they're sort of looking for. And what you'll see in then patients here with EoE, when you see red, that gene is upregulated, so it's produced more. When you see blue, the gene is downregulated. And there's a very clear, distinct difference between the patients with EoE and the normals. If you take a patient with run-of-the-mill GERD, they're going to look like this. If you take patients who start out here and put them into remission with either dietary therapy or medication therapy, this transcriptome, here's the pointer again, reverts to here. And they've showed that in multiple studies as well. So if you look at these products, if you would, it's an upregulation of multiple different Th2 molecules. IL-5, IL-13, eotaxin-3, periostin, IL-33, TSLP are all upregulated in patients who have EoE. Conversely, there's a decrease in DSG1, which is a protein that's important in esophageal epithelial integrity and barrier function. And so that is downregulated, and barrier function sort of goes down, and there can be, access of more antigens and irritants into the esophagus. And again, IL-13 having a predominant role, it's felt to downregulate the DSG1 protein.
You think that would be up in anybody that's allergic. They have allergy controls, atopics that didn't have GERD or didn't have EoE.
What would be upregulated?
Oh, just that all these other,
Not
type
necessarily in the
Th2
esophagus.
type cells.
Not in the esophagus. Right?
Oh, that's only
This is
esophagus.
tissue from
All
the
right,
esophagus.
only esophagus.
Yes,
Okay.
yeah. This is not,
They didn't do that. Did they use atopic controls?
Yes.
No, okay,
Yeah.
that was not.
Yeah, if you don't have EoE, you have a normal transcriptome.
Okay.
Yeah. So again, the
Did they look at other tissues?
Not that I'm aware.
Not that. Okay.
So in the human esophagus, IL-13 actually correlates fairly well with the magnitude of the EoE transcriptome. And Mark Rothenberg and his group had a mouse model where they induced airway expression of IL-13, and this resulted in a pattern of an esophageal gene expression and extensive tissue remodeling that resembles the transcriptome in human EoE. They've also, interestingly, found an increase in ILC2 cells in EoE, so innate lymphoid cells. And the cellular response of or sources of IL-5 and 13 are not well established, but it may include the recently discovered group 2 innate lymphoid cells, ILC2. So ILC2 cells are lineage negative in that they lack surface markers for T cells, B cells, natural killer cells, and NKT cells. But they do express the chemoattractant receptor homologous molecule expressed on Th2 lymphocytes, CRTH2. And patients with EoE had significant increases in CD45 positive, which is a leukocyte common antigen, with lineage negative lymphocytes, but they were expressing CRTH2 by approximately 25% over controls. And here's some of the data showing that if we look at the patients with EoE active disease, upregulation in these ILC2 cells. If you look at controls, significantly less. If you look at EoE that's been put into remission with therapy, again, dramatic reduction in those cells compared to the non-treated EoE patients. And then here you look at the mean number of eosinophils versus the percentage of ILC2 cells, and correlations are what they are, and so there's some correlation with an R of 7 here. Significant mast cell numbers are found in the epithelium, and again, Mark Rothenberg found a different mast cell-associated transcriptome that's very distinct from the eosinophil-associated transcriptome in patients with EoE with carboxypeptidase A3 mRNA levels being the best marker for mast cells in the disease. There's an increase in transforming growth factor beta. It's been linked, obviously, transforming growth factor beta. Growth factor beta is linked with epithelial growth, fibrosis, and tissue remodeling. And this is a process that's felt to be associated with ultimately the fibrostenotic complications of EoE. And eosinophils themselves are a source of TGF-beta, and TGF-beta levels correlate with the degree of fibrosis. Mast cells are also a leading source of TGF-beta. And recently, just to muddy the waters even more, within the last 2 years, there have been 1 or 2 reports of increased amounts of IgG4 in this disease. So they did immunofluorescence of tissue, and they looked for all different types of immunoglobulins, and they found elevated amounts of IgG4 in fixed tissue compared to controls, but no other increase in any other immunoglobulin class. And they also found trends, not statistically significant, but trends with elevated serum IgG4 to the foods that are most commonly involved in this disease: dairy, wheat, egg white, and nuts. So if we look here, these are normals. These are folks with EoE, and here's an EoE to control ratio of IgM, A, and then the different subclasses of IgG4. And if we go over to this column, you'll see that there's 45 times more IgG4 found in patients with EoE compared to controls, which is dramatically different than any of the other immunoglobulin classes. And here's the sort of serum data looking at IgG4 to wheat in the EoE patients versus controls, to egg, to milk, to nuts. These are not statistically significant. There's trends. There's a tremendous amount of overlap. So there's debate. Is this, an epiphenomena? Is this sort of a causative factor? No data really to say either way right now, just something that's starting to be looked at more. So if we sort of put this all together in the pathogenesis of the disease, you have the right genetic host, which here we go. You have probably the food antigen. There may be some aeroallergens as factors in some folks, but the predominant is the food antigen. Again, with the right immune response involving lymphocytes, eosinophils, mast cells, sets up an inflammatory profile in the esophagus, which ultimately in some folks may lead to fibrostenotic disease. So how do we treat these folks? Treatment goals include the alleviation of symptoms, control of inflammation, and restoration of esophageal function. And you can do this through 3 modalities, and sometimes you may need to combine those 3 modalities. Sort of feels like how we take care of our allergic rhinitis folks. You can sort of do, reduction in exposure. You can do medicines. You can do immunotherapy. Here you can do diet. You can use medication, and you can use dilation. And when possible, therapy probably should be best coordinated with an allergist, a gastroenterologist, and sometimes a nutritionist. If you're restricting multiple foods from the diet, you better make sure that you have a nutritionally sound diet going on in that particular individual. Unfortunately, in some of our patients, there's a mismatch between symptoms, how they feel, and what the endoscopic and histopathologic features show. And this sometimes creates the need for multiple endoscopic assessments of this disease, and we'll get to how we may be able to make that better in the future in our patients in a minute. So here are the treatment options that we're going to talk about. We're going to talk about original elimination diet. We're going to talk about different elemental diet. We're going to talk about elimination diets, 6-food, 4-food, empiric diets, allergy testing based. And then the medications will be proton-pump inhibitors we'll talk a bit about, and then 2 topical steroid uses here. So as an overview for diet options in EoE, elemental diets with amino-based complete liquid formulations are incredibly effective. Anywhere between 91 and 96% of patients respond. Might be less so in adults. That may be more compliance than anything else. If you do directed elimination diets, and we'll get to some of the data in a minute, based on allergy test results, including skin testing and atopic patch testing, probably about, in all the studies that are looked at, about 46% of your patients will respond. If you do non-directed elimination diets, based on 6 most common food antigens that have been found, empirically excluding those 6 foods, you're going to get to about 72% of patients respond. So it's felt that this dietary therapy is thought to target the adaptive immune system, presumably by suppressing antigen-driven T-cell responses, although this has not been conclusively proven. So let's go back to that landmark study, 1995. Kevin Kelly, U. Sampson found 10 patients. They put them on exclusive amino acid-based formula, and the symptoms and the histologic and endoscopic findings improved. But as soon as they added food back in, the symptoms and the histologic findings regressed. This initial study was followed by other studies using elemental diet and similar studies in adults. So whether you're a kid or adult, you respond to elemental diet. But unfortunately, the expense and the lack of patient interest in long-term elemental diet led to the development of other diet strategies. Not too many people want to keep on elemental diet their whole life. But going back, there's sort of very interesting sort of things that we can sort of look at and use moving forward if we use dietary therapy of any type. So once you get
histologic remission, in this case using an elemental amino acid-based diet, patients were having foods added back in to expand their diet. And there's a sort of list of foods that are least likely to cause symptoms, and so you'll add those in first, and then you'll get to the ones that are most often involved in the disease last. And here's a chart that has basically been used where the least likely allergenic foods in A, then to B, then to C, and then to D is the most common food. So you'll start with A, and you can add multiple foods at a time or groups of food because it's very unlikely to have problems. And then as you start moving across the column and get to D, you're adding in one food at a time, probably for every 4 to 5 weeks before moving on to another one. Now, if symptoms do not recur after introduction of a food or a food group, initially, and this is sort of not how everyone does it right now, but initially during the studies, endoscopy and biopsy were performed in 2 to 3 months to prove that not only were the symptoms better, but endoscopically and histologically, the patient was still in remission. If patients developed symptoms after you added a food, that food was taken back out of the diet, symptoms resolved, and then you would proceed to another food to be added back into the diet. But this involved repeated endoscopies over and over again. So we'll get to that sort of controversy in a minute. So people started looking at food skin tests and food atopic patch tests. CHOP was one of the leading institutions. And the use of this was initially felt to be useful and hoped to have a high degree of success. Unfortunately, over time, the work that's been done looking at skin test and atopic patch test-based removal of foods has led only to about a 45% success with a sustained response. And even Jonathan Spergel at CHOP is not relying on this sort of method anymore to sort of make his choices in diet in kids. I spoke with him at the meeting in a breakout session at the all-day symposium. So this led people to say, well, we know there seems to be certain foods that keep coming up, and so an empiric elimination of the 6 most common foods was tried. And there are more than 6 foods here, obviously, if you look at it. There's dairy, there's wheat, egg, soy, and then you get nuts, so that's a food group. That includes all nuts, and seafood, and that's a big food group. That includes seafood of all types, including shellfish. So there's a lot more than, even though it's called a 6-food elimination diet. And if you do this empirically, symptoms and histologic changes improved in about 74% of children, slightly less percentage in adults, relatively quickly. So again, the same thing would be done initially. They start adding foods back in, and then if they were asymptomatic, they would repeat endoscopies to confirm histologic changes were not reverting in terms of number of eosinophils. But again, this requires frequent endoscopies to confirm histologic improvement as you add foods back in, because the goal is to have them on the least amount of foods out of their diet as possible to control this disease. When this was done, it was found that, again, 4 foods seemed to be the most important in this disease as you started to add foods back in. Milk is clearly number 1, wheat is clearly number 2, eggs is 3, and soy follows eggs by a little bit. So people were saying, okay, if these 4 foods seem to be the most common, let's do a 4-food elimination diet. And this study was done because, again, if we can achieve the same amount starting with 4 foods, why not do that? So this study was done looking at elimination of 4 foods, and they eliminated dairy, wheat, eggs, and legumes, and didn't deal with the seafood and didn't deal with the nuts. But what they did in this initial study, at least, they said, we want to make sure we're not having any cross-reactive foods. So we'll eliminate wheat, including goat or sheep's milk. We'll eliminate all gluten-containing grains that cross-react with wheat, and not only just soy, but all legumes, such as lentils, chickpeas. So again, they were doing a little bit more than 4 foods. They also said we will use 6-food elimination if you don't respond. So if you don't respond to the 4 foods, we eliminate the other 2 and see if you respond. So what they found in the 4-food elimination, empiric elimination diet with wheat, dairy, eggs, and soy is that there was a 54% response rate. And this was including endoscopic, histologic remission as well as clinical remission. And they were able to rescue 31% who did not respond to the 4 foods by putting them on a 6-food elimination diet. So again, they could be rescued that way. And again, the same important triggers or foods were found. And so if you look at all the studies sort of together, this is a rough estimate in terms of percentage improvement. You're going to find if you put people on cow milk elimination, only 33% will improve with that. If you do, again, skin test or patch test directed, you're going to get 45% improvement. If you put them on a 4-food elimination diet, which I mentioned, 54% improvement. If you put them on a 6-food elimination, you're going to be up in the low 70%. And if you put them on an elemental diet, you're going to be at 96%. And clearly, again, the order of foods that are most important are cow milk, wheat, egg, soy, and the rest. When I've had my patients in the office, and it's sort of crazy, some days I'll have 2 of my 4 exam rooms at the same time with patients with EoE who are referred by the gastroenterologist. So seeing a fair number of these folks, I'll talk to them about options, and the option that I usually will start with if they're interested in diet is a 4-food elimination diet. Again, talking to Jonathan Spergel at a meeting this past year, he tends to start with a 3-food elimination diet. He'll do dairy, wheat, and egg, and I'll usually say dairy, wheat, egg, and soy, and then you go up or down depending on how they respond. Yeah?
Right. So you're sort of talking about this as this is a homogeneous disease in all ages, and you said in the beginning you felt it was. I don't see kids very often, but every adult that I've ever tested is flat out skin test negative to all food.
That's correct. This is a non-IgE mediated disease.
Right. So frankly, as you pointed out here, skin testing is almost useless, at least in the adult population. Maybe you could argue it's even useless in kids because you can do the same thing in diet anyway.
Yeah. So you could say that. I would not agree because they're sent to you for allergy evaluation. And if you just start right away, I think, talking to them, we can just eliminate these foods without doing any testing. They may buy into it and they may not. Again, this is a chronic disease. Compliance is a huge issue. So I will do the testing. That's why the gastroenterologist had referred them, knowing that it's, it takes 20 minutes. And then I give them a handout to read while they're timing down for 20 minutes on this disease that already starts talking about empiric elimination versus some pharmaceutical treatment. And it just, I think the process goes better that way for me personally. But you could walk into the room and say, we need no testing, here's what you got to do, and maybe they'll buy in and maybe they won't.
Well, it's like urticaria. I basically tell people now there's no point in skin testing.
Right. But you might do some blood tests.
But I mean, it makes me wonder, is this really one disease? It's so different in children and adults.
No, it's the same disease. It's just, do you have it for 2 years? And this is how the esophagus presents and the symptoms that develop? Or do you have it for 50 years? And now you have fibrostenotic disease and it reacts differently. But if you eliminate the same foods or you treat them with the same medicines, kids and adults respond exactly the same way.
So what about the patient who has just ends up having a positive skin test to another food, not in these groups?
So I think that's reasonable to say, okay, you've got a, no, let's talk about the size. The 2/4, I'd say forget about it, it's nothing, right? But if you get a 15/30 for a food, I'd say, okay, let's take that out of the diet with or without other treatment. See how you do, and then let's add it in 2 to 3 months and see if things change. But I would use that but it would not be the only thing I would use in
You'd do it
helping
with
that
the other
patient.
four
Yeah,
buttons.
I'd be doing something else, and we'll get to some of the other options in a minute. Yep.
What's the youngest child that you see or that's been seen, and is there much difference in the foods that are implicated?
The foods are the same, and kids can get it, within the first couple of years of life. Okay, so baked dairy, baked eggs. So if you have dairy and eggs involved, if you add baked dairy and egg into the diet, about 25 to 30% will fail. Means 75% can tolerate baked eggs, so you just have to be aware of that as well. So let's talk for a bit about medications here. So a lack of response to proton-pump inhibitors we sort of talked about is a criteria to sometimes rule out this, to make sure that the patient doesn't have GERD rather than EoE. And again, ideally it's a 2-month treatment. Patients with EoE often can have symptomatic GERD at the same time that does respond to PPI treatment. There are some anti-inflammatory properties of PPIs as well that have been found. And in fact, if you look at this disease, everything else, the symptoms exactly the same, histologically look exactly the same. There is about a 15% PPI responsive group. So you can basically treat and cure 15% of folks with EoE with high-dose proton pump inhibitors. There is some question whether that's forever or do they eventually relapse, and that's unclear at this time. But if you look at their transcriptome, which looks just like EoE, and in the 15% of PPI responsive patients, you will revert their EoE transcriptome to normal in that 15%. And I have a number of folks who have clearly documented EoE that this is the only treatment that we're using is PPI therapy because they respond. We have to follow them because they may, down the road, not respond. Topical glucocorticoids are a huge treatment option in these folks. Fluticasone and others have been used as well. It can be used in a meter dose inhaler. You spray it on the tongue, and supposedly just it gets down into the esophagus. You can also use a viscous preparation of liquid budesonide, which has been termed oral viscous budesonide. That's usually mixed with Splenda, but you can mix it with maple syrup or honey. The efficacy of these topical medicines in improving symptoms and histologic abnormalities occur relatively quickly. And again, depending on the study you look at, 53 to 95%, closer to probably 90% with oral viscous budesonide. You should be aware that neither of these drugs are approved by the FDA for this indication. If we look at fluticasone, doses typically range from 440 to 880 micrograms per day in kids and 880 to 1760 per day in adults. In the higher doses in kids, if you use fluticasone, there have been reports of adrenal insufficiency. So you definitely want to get them down to the lowest dose possible. A lot of studies say start high and then taper down, basically. If we look at oral viscous budesonide, again, most of the studies will mix it with a slurry of sucralose, Splenda. The usual dose for oral viscous budesonide is 1 milligram once or twice a day for kids and 2 milligrams once or twice a day for adolescents and adults. And again, you want to get them down to the lowest dose once you get the disease under control possible. For all the topical steroids that you give, it should be done after meals, and patients should not eat or drink for 30 to 60 minutes after, because you want the medication to have as much contact with the esophagus as possible. One of the earlier studies looking at oral viscous budesonide. So this is PPIs plus oral viscous budesonide versus placebos and PPIs alone. And here's the beginning with the eosinophils per high-powered field, upwards of 120, 100. And then after treatment with oral viscous budesonide, really almost down to nothing. And I want you to look at this number and remember this number when we get back to some of the other biologics that we're going to talk about in a minute. And no sort of improvement here with the PPI alone. If you look at symptom response, pretty quick within 1 month, dramatic symptom response in the oral viscous budesonide versus controls. At 2 months, it's even better. And at 3 months, it's about the same. I'll typically see patients back in about 3 months after I started them on therapy. Adverse effects of topical steroids, Candida, 10 to 15% of patients, and usually the patients are totally asymptomatic and you just find it on repeat endoscopy. If you do find it, you should treat them with an antifungal. Herpes esophagitis, incredibly rare, but has been reported. One of the concerns if you're giving long-term topical steroids is atrophy of the esophageal mucosa. And Straumann looked at this using a histomorphometry technique and found absolutely no differences in there was no atrophy of the esophagus after 50 weeks of treatment with oral viscous budesonide. Concerns about adrenal axis suppression. Fortunately, because the topical steroids undergo first-pass metabolism, such effects appear to be very uncommon, but not totally negative. So there have been rare reports of adrenal suppression seen in children treated this way. And it is seen definitely more in folks with fluticasone than oral viscous budesonide. This is a chronic disease, so you're going to be telling folks to do something long-term, whether it's diet or medication, and there's upwards of a third of non-adherence with patients following your instructions, which is probably par for the course for asthma and any other chronic disease that we take care of. A couple of minutes on dilation. And this was initially associated with significant complications. The perforation rates were as high as 8%, and many patients developed deep mucosal tears and underwent hospitalizations for post-procedural pain. So the first symposia that I went to, it was considered a very cautious approach, and dilation is really considered a third-line therapy. Don't do it if you have a diagnosis of EoE. But since that time, studies have shown that dilation can be performed safely in patients with EoE, can improve symptoms if they have a stenotic stricture, and calculation recently showed that at groups that do this routinely, the risk of perforation in folks with EoE is really much lower, 0.3%, which is similar to the rate of dilation side effects in patients without EoE. So it's an acceptable treatment now for patients with EoE, but it doesn't change the underlying eosinophilic inflammation. It's just acutely relieving the stricture. And the safety data was collected from expert centers that were doing this over and over again. We don't know, hopefully, but we don't know if low-volume centers have the same sort of safety profile. And the goal of this is actually to induce a mucosal tear. So you're going to break the esophageal mucosa at the area of the stricture. And this is not considered a complication. If you don't break the mucosa, you don't get improvement in symptoms. 75% of patients are going to report chest pain or discomfort that they'll rate as moderate or severe in 20%, and that can last for 3 to 4 days. So the endoscopist who's doing this has to counsel patients to expect this and to manage it with reassurance and analgesics for the next 3 to 4 days. It rarely requires emergent evaluation to evaluate full through and through perforation, and it does improve symptoms of dysphagia. 50% improve for the first year, and 40% are still asymptomatic in terms of the stricture for 2 years. So if we look at what's happening, this is a probe in A, and then after the dilation, you'll see the mucosal tear here. And this, if you don't have this mucosal tear, you have not successfully dilated. Here we're looking through a scope with a balloon, and then after the dilation, again, you'll see the mucosal tear here. So this is what the endoscopist is looking for, and if he doesn't see that, he's going to push harder. A minute on biologics. So anti-IL-5, both mepolizumab and reslizumab have been studied for the treatment of EoE. Makes sense, reduce eosinophils. There have been encouraging histologic improvements, but they have not shown clinically a response that's different from placebo, and we'll look at that in a second. Omalizumab has been studied. It doesn't work. Again, this is not an IgE-mediated disease. Monoclonal antibodies against TNF have been tried. It doesn't work. So if we look at one really big Reslizumab study in EoE, patients, kids mainly were assigned to 1, 2, or 3 milligrams of Reslizumab or placebo for 1 month injections for 12 weeks. And the Reslizumab definitely reduced the number of eosinophils in the esophagus in patients with EoE. But when they looked at all treatment groups, including the placebo group, they could not show any significant clinical difference. And I'll show you that data in a second. Let's spend a second on this. So here's baseline eosinophils, and then patients treated with Reslizumab at 1 milligram, at 2 milligrams, at 3 milligrams, and then placebo. So the placebo eosinophils didn't change. Those treated with Reslizumab definitely reduced. But if you look at the numbers here, a lot of them still have 30, 40, 25 eosinophils per high-powered field. Going back to oral viscous budesonide, many of those patients had 0 eosinophils per high-powered field. So whether the dose or this treatment is never going to get you to that number, we don't know. But it's not getting you as low as oral viscous budesonide. If you look at the symptom improvement global assessment, here's a 1 milligram group showing significant benefit. Hey, this looks really good. The 2 milligram still looks great. The 3 milligram looks even a little bit better. Unfortunately, for whatever reason, unexplained, the placebo group improved the same amount. So this really put a squash on this medicine. That being said, at the Academy this year, there were 3 or 4 kids who responded dramatically on Reslizumab. Their eosinophils went to 0, their symptoms went to nothing, and through compassionate use, they were kept on Reslizumab for 5 years, and they have continued to have no disease. So again, I think this medication, this class of medication still has promise, whether the dose needs to be changed or something else needs to be done, or maybe pick a group of placebos that don't get so good.
Is that the only treatment in those kids? No diet?
Correct. So anti-IL-13 has been looked at. In one study, the responder rate was 40% with anti-IL-13 compared to 12% with placebo. The amount of eosinophils in the esophagus was decreased by 60% with anti-IL-13 versus an increase in eosinophils with the placebo group of 23%. And that decrease was sustained after one treatment for 6 months. There was a trend, but not statistically significant, improvement in symptoms, particularly dysphagia. And anti-IL-13 improved the EoE-relevant transcriptome that we talked about, particularly by reducing eotaxin-3, periostin, and other markers of mast cells, and also improved the barrier function marker, DSG1, and it was very well tolerated. So if we look at, again, anti-IL-13, the eosinophils go down with treatment. With placebo, they don't. If you look at the mean reduction in eosinophils, the blue is the anti-IL-13, and the tan is the placebo group. If you look at the transcriptome very quickly, this is at baseline. Here's placebo after 85 days. Here's a transcriptome for the anti-IL-13 group. And what you'll see is there's a reduction in Th2 markers and an increase in DSG1, improving barrier function. So again, potentially a very important treatment down the road, but we just don't have the data. Other agents, not going to do that. So I think I'm going to end with one thing. I'm not going to get through all the slides, but I think this is really important for you guys to know. The goal of this disease is to obviously reduce inflammation, improve symptoms with the minimal amount of medication and the minimal amount of foods that are eliminated. So you're going to try to taper meds once you get them under control. You're going to try and add foods once you get them under control. Unfortunately, clinical symptoms correlate with endoscopic and histologic remissions with only modest accuracy, a real bugaboo, because that means endoscopy with biopsy is the only currently reliable method to, in fact, prove that you have histologic remission in these patients. In children, endoscopy requires general anesthesia and poses a significant patient burden due to the invasiveness of general anesthesia and repeat endoscopy. So the need and the studies for less invasive ways to measure histologic changes is really critical. And I think I'm going to end and not finish the rest of it, but I want to end with some of the non-invasive methods. String test, we're going to talk about cytosponge test. There is a nasal endoscopy that's being studied where you can do it in the office, nasally go down with a very, very thin scope and actually see and take biopsies. And that may be coming down the road as well. The one that's probably farthest along is the string test. And this is basically what it looks like. This actually was originally used for diagnosis of giardia. So you would basically take a capsule, swallow it, the tape would come out, the string would come out, you tape it here, and then they'd pull it up and see if you had giardia. Well, a group in National Jewish started using it to diagnose EoE, and they did it overnight, but now they have it down to a 1-hour test. So they come into your office, you'd have them swallow this string, sit there for an hour, you'd pull it up, and you'd measure eosinophil-derived proteins by ELISA in aluminum effluents from the string, and here's what they found. Busy slide, let's just look at the top one looking at major basic protein. So this is major basic protein in biopsies, and this is major basic protein from the string. And here's active disease, and what you'd expect is there's a lot of major basic protein in the biopsy as well as the string. Here's treatment group, so they're in remission and significant reduction. Here are patients with GERD, very little major basic protein, same thing here, and here are normal. So again, fairly good correlation with the disease. And again, if you look at just the biopsy major basic protein on the x-axis and y-axis, the string, major basic protein, pretty good correlation. And so this test, hopefully, is supposed to be available within the next 12 to 18 months that we could use to follow our patients as we add foods in, reduce medications without having to do endoscopy after endoscopy after endoscopy. Cytosponge, similar concept. You sort of swallow this. This actually was originally used to diagnose esophageal cancer in high-risk genetic populations such as Japanese and Asians. And so when the capsule dissolves in the stomach, you get this sponge, and then you slowly pull the sponge up through the esophagus and collect eosinophilic products. This has an issue. If you have a stricture that's 25 millimeters in diameter or smaller, you may not be able to get that sponge through that stricture. So that's very critical if you're going to do that, basically. And so again, these are really going to, I think, revolutionize how we can track our patients, not just knowing clinically how they're feeling, but really histologically, do we still have them in remission? All right, just so you know, if you put your patients on food oral immunotherapy, some of them are going to develop EoE. Okay, how many? We don't know yet, but the best data, probably looking at meta-analysis, is 2.7%. About 3% of your food OIT patients are going to develop EoE. You're going to have to stop the OIT, basically. If your patient has EoE, it's contraindicated to put them on SLIT. Do not use SLIT therapy if your patient has EoE, because it can make EoE worse. All right, we're just not going to have time to do this. Here's an algorithm. Take a look at it. You know, at the end, this is how you can sort of manage patients. There are some refractory patients who you have to go back to elemental amino acids. You have to sometimes put them on prednisone. You may have to consider immunosuppressants, but most of your patients can be managed with diet and or topical steroids. Yeah, Paul.
Is Rothenberg's transcriptome test available anywhere outside his lab, and has he followed them with that to see if it correlates with these other with these other ways to follow.
Yeah, he has. It's, as far as I know, it's not available. It's incredibly labor-intensive and costly to do. And if you look at the sort of sensitivity and specificity of just number of eosinophils for a high-powered field, it's as good as not better than the transcriptome. So don't bother. Yeah.
So I was also at the Reslizumab and EoE talk. The speaker kind of mentioned that he thought that there was maybe like the physician's assessment they used wasn't necessarily the best measurement.
There's something totally bogus about the number of placebo people who improved. So if that medicine or something like it doesn't get re-looked at, I'd be surprised.
Here's a question here by Chuck from the outside here. With the majority of patients having no evidence of IgE sensitization to food, what other mechanism explains the effectiveness of food elimination? And the second question, IgG4 usually associated with reduction in IgE sensitization, where EoE it's elevated against the foods postulated to have the etiologic role, and why is that?
Okay, so there's two questions there. So, yes, this is definitely a food antigen-induced disease, but it's not induced by IgE. I mean, so it's a non-IgE food antigen-induced disease, probably through lymphocytes, mediators inducing the influx of eosinophils and mast cells. That is not through an IgE mechanism, clearly. So we know that there's food protein-induced enterocolitis induced by foods, totally non-IgE, similar type issue. The mechanism is probably different, but it's probably potentially an innate lymphocyte type 2 cell that is inducing products that are causing inflammatory cells to come in, but not through IgE. The IgG4, again, I'm not saying this is the cause. You know, no one is, but it's just something that's recently been found. Whether it's a cause or just an epiphenomena is unknown. But again, you got a lot of lymphocytes, you got a lot of other cells that are there, and whether it will be causal or not is unknown. But this is a non-IgE mediated disease.
Yes, sir. If we were sitting here 10 years ago, we would be talking about how it's a mixed IgE, non-IgE mediated disease. And so they looked at IgE knockout mice, and Spergel is a big T-cell guy, so he'll talk about how IgE knockout mice, it made no difference. These mice still had EoE. But you still have, I think we still have this subset of patients in different phenotypes where, you know, kids who are very atopic, and they showed I think one of the former fellows at CHOP showed that it was just one patient where during peak pollen season, eosinophils in the esophagus increase, and that's where a lot of people get diagnosed. So there's got to be something going on in some of these patients who have oral allergy syndrome, for example, who are test positive to many things.
Yeah, so I would agree. I mean, if you look at the original chart that you, Samson, put out, you know, in reviews, this is a mixed, yeah. But I would say now,
primarily T-cell mediated.
This is a T-cell mediated disease that there may be a rare individual that has an IgE component to their disease. So let's not say never, but let's say rare, unusual. Don't look for it all the time.
Well, that being said, what's the role? My whole thing about this is what's the role of the allergist?
I think the role of the allergist, truthfully, is to manage this. I mean, I don't know. So children's GI people may take the bull by the horn and take care of everything. I don't know. But the folks who referred to me, basically, they're called into the ER, or, you know, the patient comes to the endoscopy suite. They have their symptoms, and they say, you have this disease, get out of here. And I'm managing them because they're get out of here. You know? So if you have a gastroenterologist who says, okay, we've got the nutritionist, we've got the help, we're going to manage the diet, we're going to do the pharmacotherapy, then your role may not be so significant. On the other hand, with the non-invasive modalities that are coming down the road, including the potential ability for you or I to do nasal endoscopy, which is a fairly simple procedure in your office, you may take that role over. But I have it for most of the adults because the GI folks don't want anything to do with it.
Yeah, I think it's like we ought to embrace it. It's like urticaria is not an IgE-mediated disease, but every non-allergist thinks it is, and every patient thinks it is, and that's a big part of our practice. So as rhinitis becomes a trivial part of our practice.
And it's an immune-mediated disease. involving lymphocytes, eosinophils, and mast cells, and probably no one knows how to handle those and knows the physiologic mechanism of those better than us.
And I think in children, there seems to be much more atopy and IgE mediated, at least associated disease like allergic rhinitis and asthma.
The adults have it. The adults have it too. The adults
Yeah.
have it too. It's just that it either doesn't bother them or they can manage it pretty
Right.
easily.
Right.
Yeah.
Just from Everett community, the number of GI docs who want to manage this disease is 0 out of 50.
Right.
They don't want them at all.
Right. They want to do their
diagnose them,
endoscopy.
they're out the door, go see the allergist, and that's it. So they don't want to see them back, they don't want to follow them.
Yeah.
I would think that they'd want to scope them over and over,
Right,
but they
and
don't want to do that.
I mean, I have to sometimes beg the GI people to scope this person again because I'm not sure where my treatment's going. So when we have these non-invasive modalities, it'll be very slick.
So viscous budesonide is still the king so far of treating these people?
That's what I use if they opt for pharmacotherapy. I usually will discuss the options, diet, and pharmacotherapy, and if they choose pharmacotherapy, that's my treatment of choice. And even many who started with fluticasone, I think, have morphed over to oral viscous budesonide. In terms of success rate and in terms of even less side effects than fluticasone.
Anybody tried Gleevec in any of these people?
I've not seen anything with Gleevec at all.
Just
Yeah.
an odd thought.
Yeah. I haven't seen that. Thank you.
Thank you.